Dr. Brew, take it away.
Thanks, Gene. Thanks for inviting me today. It's really a pleasure to be here at this town hall meeting. So my name is Bruce Brode. I'm a dermatologist. I'm a board-certified dermatologist, board-certified pediatric dermatologist, and I direct a clinic at UPenn in Philadelphia that specializes in treating patients, some of the patients with the most severe forms of dermatitis. So these are patients that whose lives are debilitated by chronic itch and chronic skin disease. I spend most of my time seeing patients, general medical and surgical dermatology, who have disabling conditions of the skin, like psoriasis, severe acne, and skin cancer. I feel like I'm practicing in the best of times predominantly, but sometimes also the worst of times. I mean, we're truly living in an age of miracles in terms of the medications that we have for our patients that we didn't have over 20 years ago when I started practicing. And I realize it's one of our responsibilities as physicians, as healthcare providers, is to be cost conscious when selecting a treatment. But I can't tell you how frustrating, and I think that's an understatement, it is for me and for our patients when we have to jump through excessive hoops to get our patients what we know, based on our experience and training, are the most effective medicines to treat their conditions. So, you know, and in the early days when I started practicing, my biggest headache in terms of step therapy from the insurance companies was getting my choice of antihistamine approved by the insurance company. So dermatology, we deal with skin conditions, we have itchy patients, so sometimes we use antihistamines like Benadryl, which is over the counter, and Zyrtec to control itch and to control hives. Now, at one point they were prescription. So if a patient had hives years ago, I wanted to prescribe Zyrtec when it was a prescription drug, when it was the newest drug. The insurer would tell me the patient has to have failed other antihistamines like Benadryl and Atarax, except we didn't like to use those first line because they caused a lot of daytime drowsiness. So it actually got to the point I became so frustrated one week that I started writing on a prescription pad for patients to take to the pharmacy. I'll see if I can hold this up. Antihistamine du jour, just to make a point, because the prescription that I wrote was typically never covered, so I never knew what was going to get approved by the pharmacist. So I changed the name of this prescription pad that I have to a suggestion pad. And I'd like to reverse those times. So picture this scenario. This is sort of a true story, but it's a common story also. So I had a 10-year-old child with psoriasis. Psoriasis involved his face and his genital region. And for those of you who don't know what that might look like, I don't know if this projects, but I'll show, these are pictures of psoriasis in a child. You can see widespread redness and scaling all over the skin. Here's another picture. It involves, see if I can get it on the screen, the nails, the hands, and just a horrific condition. So you can imagine a child with this. Kids have enough problems just growing up in a normal existence. The embarrassment. So the child goes to school, his face is red and scaly. The child goes to the swim club, wants to change into his bathing suit and has to hide around the corner because he has psoriasis. Is all the genital skin. So they finally get to me, the dermatologist. Their pediatrician has been trying to treat them with various cortisone creams. And imagine the disappointment when we find out that some of the topical medications that I want to prescribe beyond what's already been tried that I think will be effective for this child aren't covered by the insurance company. So for instance, sometimes we'll use something called tacrolimus ointment. Sometimes we'll use vitamin D analogs because, but they're not covered. Why? Because the patient hasn't gone through the arbitrary step therapy laid out by the insurance company. So this was a real instance. I saw this patient recently. His step therapy requirements required him to have failed a stronger topical cortisone cream and also a cream that contains coal tar. Now, two problems with that, and so essentially the insurance company is making a decision on his medical treatment. The problem is we don't like to use strong cortisone creams on the face or genital area because they cause tremendous side effects, thinning of the skin and other rashes. The other thing, if you can picture, is imagine if we have to have this child use coal tar, that's sort of a black salve ointment, to his face and genital area first before we can prescribe more effective and safe, elegant medications. How is that going to be perceived by his peers? It's going to stain his clothing, and it doesn't work as well. So basically, by the time we finally got this kid to the medications that I wanted to use first line, it was 3 visits later, and he had a more prolonged period of suffering from his skin disease. I think psoriasis is probably the best model in talking about step therapy and how it impacts dermatology patients. It's one of the more common and one of the more severe skin diseases that we treat as medical dermatologists. Patients with psoriasis not only suffer from their skin disease, but they're depressed. They lose time from work, and it's a systemic disease. Not only does it affect their skin, it affects their joints. The costs are tremendous. So psoriasis, not only, I'm not talking about the cost of treatments, but the indirect costs of treating psoriasis are amazing. These patients lose time from work. They have medical appointments that they have to keep, and it's a real disability. In a recent study that came out in January, the yearly indirect costs, so not the cost of therapy, but the societal costs, ranged from $24 billion, that's billion with a B, to over $35 billion. Now, when I first started practicing dermatology, there were more limited treatments for psoriasis, and these are effective treatments. Light therapy, phototherapy, we use topical therapies, and for patients with more widespread psoriasis, we use stronger oral medications like methotrexate and cyclosporin. But today, there are new medications, there are biologic drugs, and even some oral drugs that are amazingly effective and that have advantages over some of these other therapies, but unfortunately our use of them is limited by step therapy. So while dermatologists are comfortable using the old drugs like cyclosporin and methotrexate, the reason we have these newer drugs is because those drugs weren't as effective, although we still use them, and they have significant serious side effects, toxicity to the organs, the liver, the kidney, and the bone marrow, and they require a lot of monitoring. I'll show you some pictures of adults. This is from a textbook, so I don't think it's an issue in terms of HIPAA, but I don't know if the audience hopefully can see. But this is what severe psoriasis looks like. Widespread, thick, scaly, painful plaques all over the body. These are some pictures here that you can see where it affects the nails, it affects the palms, where we depend so much on our hands and the soles of the feet. There's no single best drug for psoriasis. But with the advent of the biologics, it's been one of the greatest advances in my professional career. Many of these drugs, many of the biologic drugs, and the predominant class are TNF inhibitors, have been on the market and approved by the FDA for well over a decade. So these drugs are being impeded, as well as some of the other biologics, by step therapy. And I think the point I want to make is it's not like these are newfangled drugs. It's not the latest craze of drugs. These are drugs that have been accepted standard therapy in patients with psoriasis for over a decade. I would estimate that over half the patients that I see that are candidates for these biologic drugs, which really help control their psoriasis, have to go through step therapy, which means they have to fail treatments that I, as the specialist in dermatology, don't think will necessarily be the best to treat their psoriasis. The most common drug that patients have to fail first is methotrexate. And while it is a drug that we're comfortable using, methotrexate has 12 black box warnings on it. Now I sort of printed this off this morning. So this is 2 pages regarding methotrexate of black box warnings for the drug. What's a black box warning? It's the most severe warning issued by the FDA. 2 of the black box warnings that I want to point out, one is fetal toxicity and the other is hepatic toxicity. So fetal toxicity means the drug causes birth defects. Hepatic toxicity means it can cause cirrhosis of the liver. So I'll give one example. Imagine, and this has come up innumerable times, that a young woman presents to the office in her early 30s with psoriasis all over her body. Debilitating to her basic existence, and you have to break the news, I do, that her insurance company requires her first to take methotrexate for her psoriasis, and then, if this doesn't work, she can be then prescribed a biologic. So basically, her choice is to delay, if this is something that she has planned in her life, childbearing, to go on the methotrexate because that's what the step therapy requires, or live with her disease rather than go on a drug that's been around for a while, one of the biologics, that has a higher safety profile and have clear skin for life. Another common scenario is a middle-aged man comes, he has psoriasis all over his body, it's on his hands, he works with his hands, he can't work, but his condition is complicated because he has a mild form of alcohol dependency. Alcohol, of course, is toxic to the liver. But step therapy would require him to go on methotrexate first, another liver toxic drug, so that basically he's being asked, and we're being asked to first put him on a drug and risk liver toxicity and cirrhosis before going on a biologic, which would clearly be a much better choice for him.
And that's exactly the point, Dr. Bird, that the insurance company is making us make these choices where we have to just do what an insurance company bureaucrat wants and not what the physician and the patient need. I just want to quickly remind people, if they want to ask questions, they can click that link on their screen and the Q&A will pop up and we'll ask that. And I didn't mean to cut you off there, but I want to keep moving so the other folks get a chance to present, and we'll come back to you with some questions.